Welcome to this series of CTSnet roundtable discussions. My name is Leanne Harling, and I'm here at STS in Phoenix with three eminent surgeons in the field of minimally invasive thymoma. I thought perhaps we could start by introducing ourselves.
Hello, I'm Joel Dunning, surgeon from Middlesbrough in the UK with an interest in minimally invasive thymectomies.
Hi, I'm Suda, Fujita Health University, Japan, and I'm going to talk about the minimum invasive thymectomy using a subxiphoid approach. Thank you.
Hi, I'm Blair Marshall, thoracic surgeon, Washington, D.C. at MedStar Georgetown University Hospital. And I, like my panel, have an interest in minimally invasive thymectomies.
Thank you. I thought perhaps we could start by talking about how we've seen the surgery for thymic malignancies or thymic tumours evolve over the last sort of decade, the shift between open and minimally invasive approaches. What kind of proportions are you doing open versus minimally invasive these days? Dr. Marshall.
Well, I think, there's 4 thymomas in mediastinal tumors versus non-thymomatous myasthenia gravis. And I think actually the majority perform thymectomy for non-thymomatous myasthenia, minimally invasive. And I think that as you move into thymomas and tumors, it has to do with the surgeon's level of comfortability. In our practice, we've continued to sort of push the limits on what can be done minimally invasively, and pretty much unless there's obvious vascular invasion, I start most cases just with a camera and just see what we can do. So I would say that pretty much probably 90% of what we do is done minimally invasive now.
Dr. Suda?
Yeah, endoscopic thymectomy has developed over the past decade, and I think the advent of the robotic surgery and development of the subxiphoid approach is important. And I think the robotic surgery make the complicated operation easy, and the development of the instruments such as the vessel sealing device make the single port thymectomy possible. So I think the development of the engineering had a major impact on surgery in recently. And I think 90% to 95% of the thymoma is performed by VATS in my institute. Thank you.
Thank you. In 2012, we changed from stenotomy to VATS thymectomy, and we just vastly increased the number of people suitable for surgery. Prior to that, small mediastinal masses were being watched and observed, and they waited till they were large enough for biopsy. And we've been able to transform that and actually allow those people to have diagnostic and therapeutic intervention much earlier. And then when people saw the benefits of VATS thymectomy over stenotomy, then suddenly this group of myasthenics who weren't previously being put up for surgery because people felt in the UK it was maybe a little bit too invasive having a stenotomy for a young 18-year-old, were then coming for surgery. And so actually out of all the endoscopic operations that I do, thymectomy is the one that's really exploded because of converting from stenotomy to VATS.
Thank you very much. With the VATS approach, I think there's lots of different ways of patient positioning, unilateral versus bilateral. What are your feelings on how you go about your VATS thymectomies?
Again, it'll depend on the indications. For me, for non-thymomatous myasthenia, typically I will come from the left side. And the reason that I like that approach is because it really allows you to get an excellent view of the aortopulmonary window and get that fat pad all the way down in the window. I've tried subxiphoid, I've tried right side. Sometimes I'll put an extra port in the right side, but for the most part, for myasthenics, I approach it from the left side.
Okay. Because before I explain about the indication of the subxiphoid approach, I explain about the three types of subxiphoid approach. I reported single port thymectomy using a subxiphoid approach, and dual port thymectomy, which is similar to single port thymectomy, but involves the addition of a port in the fifth intercostal space to improve the maneuverability. And I reported the trans-subxiphoid robotic thymectomy using a Da Vinci surgical system for the advanced tumors. And in those subxiphoid approaches, cameras is inserted through the subxiphoid incision. The operative field similar to that in median stenotomy, enabling the good visualization of the neck area and both phrenic nerves compared with the lateral approach. So single port thymectomy is indicated for the cases with no infiltration of the tumor, and the cases in the cases where the infiltration of the pericardium, dual port thymectomy or robotic thymectomy is appropriate because of the requirement of the suturing. So I think suturing is possible by the single port technique, but it's difficult. So I think the robotic thymectomy or dual port thymectomy is appropriate. And in the cases where the infiltration of the vessels, I think it is standard to perform a median stenotomy. Thank you.
I like trying different things. I've tried a bit of everything, and I certainly encourage surgeons to go and look at all these excellent videos. I've seen both your videos, and I think the most important thing is to decide what is the most important thing to you in this particular operation. So myasthenics need everything out. If you've got a thymoma and a few other conditions, you really want to get up into the neck, and then the problem with a lateralized approach is always the opposite phrenic. So each one has its pros and cons. I certainly encourage anyone out there to try lots of different approaches before you hone down on yours. And currently my favourites are sort of 2 5mm ports either on the left or the right, and then a subxiphoid approach. And towards the end, exactly as you say, if you get your camera in the middle, you can look right up into the neck, and then use Blair's excellent advice on her videos about exactly how to get those superior poles out, because that's when we'll really have equivalence to the open approach. And that is the thing that we have to make sure that we're doing the same thing as open. We don't want to be taking shortcuts, especially in myasthenics that are young and have got the rest of their life ahead of them.
Dr. Marshall, do you want to tell us a little bit about your tips for ensuring complete resection in the neck particularly?
And just to comment on the subxiphoid incision, when I do a left side, I put one of my ports very far, almost the mid-clavicular line, so that with an angled camera you can go up over on that right side and look down at the phrenic. So you can get that view if you're using an angled camera. And then to get the neck to open up, and this is possible in the majority of patients, although occasionally I've run into a patient who has very large clavicular heads, and that can be more challenging to work around. But I like to use a lot of CO2 insufflation, and that allows that space to open up in the neck. I always leave the neck prepped in just in case, because I think that we should not ever compromise the operation. And I think there's a feeling that when you use VATS, you're not doing the same operation as open, whether it be for lobectomy, esophagectomy, but I don't think that that's actually what we would agree on, in that I do the same operation that I'm doing open, just with it under camera guidance. And that camera allows you to see a lot more, actually, that you can if you were just looking down on the patient. Prior to the VATS approach, I used to do a transcervical approach, and I didn't like it because it didn't allow you to see the AP window that well. I think with the CO2 insufflation, that's another tool that if you don't have experience with, to start adding into your armamentarium. And although there can be some hemodynamic changes with the pressure insufflation in the chest, as you become more and more familiar and comfortable using it, you can even, in select patients, raise that pressure up. And so sometimes if I can't see up in the neck quite well, instead of, I usually keep the pressure at about 10 millimeters, I'll increase it to 12 or even sometimes 15, just to get that view.
And some surgeons sort of ask me about little tips sometimes of using single lung isolation, and I just don't use that anymore, because you want both lungs fully inflated, and then you want to crank up the pressure as much as you can with the CO2, because it's all at the front. The lungs are going to be well out the way, and get both pleuras widely opened, and then use that CO2 to get the good view. It's transformational. It's virtually not possible to do the operation without CO2 unless you're going to have hooks, which are occasionally used. So.
Dr. Suda?
Yeah, I usually use the CO2 insufflation is essential for my subxiphoid approach, and I perform the CO2 insufflation at 8 millimeter of mercury, and 8 millimeter mercury displace the lungs and pericardium and open up the space behind the sternum. And I think 80 millimeter of mercury is not avoid the ventilation. So we don't need any lifting the sternum. So I think the CO2 insufflation is very good method for the surgical exposure.
Thank you. How do you feel that devices have transformed the minimally invasive resections over the last sort of few years, particularly as more things are becoming available? Is there anything particular that you like to use that you find facilitates surgery?
For me, I'm enormously dependent on bipolar sealing devices. And as you mentioned, I think it's transformed this and thoracic surgery. I can't remember our last chyle leak for any operation. And so there's no bleeding in these patients, which allows us to not even leave a chest tube. And then those patients can even go home earlier. And so I think it's just amazing. I don't know what your experience.
Yep, so Bipolar Energy is brilliant. I've started using robots, which is a great device. But really, I mean, thymectomy is not, standard size thymectomy is not the world's most difficult operation. That's the thing. If you get good vision, good CO2, you don't need a whole lot of equipment. It's a cheap operation. My managers love it because, no staplers. So actually, good vision and good technique sort of is doing really well.
And how do you manage the veins draining from the innominate?
I sometimes have Bipolar Energy. Sometimes I clip. So, but exactly as you say, I love your way of, if we can get the drain out, they can go home the same day. So it is absolutely vital to try and get them as dry as you possibly can, isn't it? Because if you can get that drain out immediately post-operatively, you've saved a day, haven't you? Mm-hmm. So.
I usually use only the ligashore Meridian type on the right hand, and one grasping forceps designed for the single port surgery. That's 2 instruments. That's all. Mm-hmm. So, and I don't use clip. I don't use any stapler. Mm-hmm. So yeah, as he said, it's very cheap operation.
And I think to sort of start to wrap things up, talking about robotics, we've mentioned it a few times. How much, what proportion of robotics are you all doing now, and where do you see that going in the future? Do you think we're going to move more towards a completely robotic approach, or?
I love the robot, but to get time with our robot is so challenging, and I can just do it more simply with VATS. So, but I think it's an incredible device, and so I'll let you guys answer that.
Well, certainly for myself, I've used the robot a few times for exactly like you. It's time on the robot and it takes longer. So the ports are larger with the robot, and as you said, it's a simple operation. So I use 5mm only instruments and a 10mm port to get it out. And so actually that's smaller incisions and probably a little bit quicker for most thymectomies. So the future probably will be a robotic style procedure, a uniportal robot that could bring arms out through a single hole. You'll be able to do everything then, but that's not here yet, but it's close.
Yeah, I reported transsubxiphoid robotic thymectomy, and the transsubxiphoid robotic thymectomy made 3 centimeter subxiphoid incision and 1 centimeter incision for bilaterally, and that transsubxiphoid robotic thymectomy is indicated only for the advanced tumor, because I think the single port thymectomy using the subxiphoid approach is the most minimally invasive approach for the patient and low cost. So I indicated single port thymectomy for the cases with no infiltration. But some cases, for example, if the patient and the tumor infiltrates to the pericardium, we have to resect the tumor with pericardium, and we have to make suturing for the reconstruction of the pericardium. So we have to use the Da Vinci system for the suturing. So I just performed only for 8 cases so far, and but I think it's very useful for the suturing in the narrow space by the multi-joint system of the Da Vinci system. So in the future, as he said, if we have single port robotic system can be developed, I'm looking forward to use that system for my single port thymectomy.
Well, I think we're kind of running out of time, but thank you very much for all of you for a fantastic discussion. It's been really insightful, so thank you very much.
Thank you.
Thank you.
Thank you.